All right. Okay, so for those of you guys who don't know me, like Jeff said, my name's Gina. I just was talking to Jeremy and looked around the room. There's at least 10 people in this room that I've never seen before.
Well, maybe if you came around a little more often.
Sorry. Well, no. I did work at Christian full-time for about 10 years until about 2 years ago, and then went part-time. So I'm still there randomly when Shannon allows me to pick up a shift. Thank you. I'm one of the outreach coordinators for St. Louis Children's. For those of you guys who knew Sabina, she also works with me at Children's. So her and I are the ones that go out and do outreach. If you get like a random letter on follow-up, that's from me. So today we're going to go over some pediatric respiratory, talk about emergency management of pediatrics, specifically because we're getting into like flu season, RSV season, things like that. So this is a bunch of stuff that you guys will be running into. First slide, who's afraid of the pediatric patient? I put everyone's hand up in this picture because you are. And if you're not, you probably should be, except for John. Everybody else, though, should probably be scared. So, some objectives that we're going to go over today. First thing is you're going to describe the unique characteristics of the pediatric airway and the respiratory system. I'm sure you guys have all heard kids are not just little adults, and then you've heard kids are, in fact, just little adults. I like to say that in the context that in an adult, if you find a problem, you fix it. It needs to be exactly the same with kids. It shouldn't be, oh, we're on our way to Children's or Glennon, they'll see a doctor in 15 minutes, let's just let them deal with it. That is not the correct thing to do with children. All right? So, define respiratory distress and failure. Recognize the signs and symptoms associated with respiratory distress and failure. We're going to discuss some common pediatric respiratory illnesses and emergencies. And then we're going to discuss the steps in managing these emergencies, and I will bring it to chem specific, so I will be quoting your guys' protocols, our protocols. So your respiratory system, there's 5 different components. First thing is the central nervous system. So this is what controls your ventilation, controls your rate. This comes into play if they have any type of like trauma or pre-existing central nervous system issue that affects their rate. Trish is going to talk a little bit further into kids with like hypoventilation syndrome and things like that. Later on when we get into like the STARS talk. But in the meantime, for you guys, kids may present like if they were just hit in the head or something and they're having issues with their breathing and such, they may have injured their central nervous system. So at that point in time, we take over breathing for them. Next thing, the actual airways. The airway itself is present at birth. Okay, those are the tracks that go down. We'll get into the alveoli here in a second. We'll get into the surface of gas diffusion. But the chest wall, the respiratory muscles, all of these come into play with kids because they are way more. I'm sorry, Tom, you have to stay over there. The chest walls and the muscles are a little bit more compliant in children than they are in adults, and that does make a difference when it comes to how tired they get the longer that they have issues breathing. So what makes kids different than adults? Number 1, their tongue is larger, leaves little room for swelling. Okay, so if you have a kid who's having some type of an anaphylactic reaction or something and their tongue starts to swell, we don't have 10 minutes to get to the hospital to give them stuff. We have to act now. All right? Their pharynx is smaller, which again comes into play if they have any type of swelling in the back of their airways. It's much smaller. Trish will go into detail on how big and small the actual pharynxes are when she talks about trach care. Epiglottis is larger and floppier. I'm not going to talk about epiglottitis. Later on, everybody learned about epiglottitis when they're in paramedic school, right? Or EMT school, and it became like this huge thing. It's kind of like quicksand. You thought you were going to like really see a lot of it when you were younger. Turns out you don't see a lot of it at all. So we're going to kind of skip over the epiglottitis. Their larynx is more anterior and superior. The cartilage is much softer, which also comes into play when you're trying to intubate these children. Who here is intubated let's do infant. Who's intubated an infant? What about ped? We definitely need to practice that. All right. Narrowest at the cricoid. This says it limits the ET tube size. I know here we carry uncuffed tubes. There's a huge wave that pediatric facilities want everyone to start using cuffed tubes in children now, especially when you're using positive pressure ventilation, which is when you guys would be intubating them. So we need to work on that, but we understand if you guys don't have this, that's fine. And then the trachea is narrow, it's much less rigid. You'll notice in adults, your trachea is very rigid, and it's because the rings of your trachea are fully enclosed. They're an O, which keep your trachea nice and rigid. In kids, it's a C, not an O. So if you've got a C, it's much easier for the trachea to collapse because it's not rigid all the way around. That's why they have floppy airways. They are obligate nose breathers, specifically when they're much smaller. So that becomes into play when you've got a kid with congestion. So how many times you guys pick up a kid because mom says they're just sick, they need to go to the hospital, look at all this green stuff coming out of their nose. And how many times do we just throw them in the ambulance and then we just take them to the hospital? You could be doing some good by just suctioning this kid. Okay, it comes into play a lot with infants. Okay, so again, your ribs, they're much more compliant, which brings out retractions. Okay, does everybody know what retractions look like? Right, retractions start low and they end up high. So if you have a kid with supraclavicular retractions, that means that they've been working for quite a while. Okay, because they all start off low and end up high. Respiratory rates, okay, it absolutely matters. And if anybody's ever had one of my talks in the past, and I put that picture up from The Simpsons where it says Christ is watching, and it says very clearly when you write 16 or 24 for your respirations, I promise you this kid's respiratory rate is not 16 or 24, so please do not write that in your report. You have something in the back of your ambulance that counts your respirations for you. What is it? Capnography. Why are you not utilizing these tools? I don't know. Please, for the love of God, use them. All right, and it absolutely matters in these kids, their respiratory rate. And we'll talk about why here shortly. And I don't expect you guys to know this, okay, because I don't know this and I work for a pediatric facility. I have to reference my tools. What tool do you have in the back of your truck that tells you normal respiratory rates for these kids? That works too. Your hands heavy. Where's your hands heavy bag when you go in on a pediatric call? And don't lie. It's locked in your truck. Okay. Please use the tools that you've been given. All right. When you go in on these calls. If you need to take that out and put it in the side of your monitor because and I don't want to mess up 5S stuff because I know it's supposed to be in the 5S bag. But if you want to go ahead and put that in the side of your monitor, which you're actually going to use in order to get the vital signs, I think that would be beneficial because you're never going to not have the monitor when you have the PEEP bag. Okay? But you should always have something that tells you the correct vital signs for these kids because they do matter. All right, definitions for respiratory distress. First thing is just any increased work of breathing. Okay? Give me an increased work of breathing for an infant or a child. What is a sign of increased work of breathing? We just talked about one. Tachypnea. What else? Flared nostrils. Retractions. Head volume. Sorry?
Nasal flaring. Intercostal retraction.
Thank you. All of these things are signs of increased work of breathing. Here's my question to you. If you see nasal flaring in an infant and you notice some substernal retractions, but their oxygen saturation is 100%, are you going to put them on oxygen? Because you should, okay? We all know that kids compensate, and then they drop off. Just because a kid is compensating well does not mean that they're going to compensate for long, okay? I wish I could rip the pulse oxes off of the trucks because I don't care what their pulse ox is. If they have an increased work of breathing, they need oxygen, which means you give it, okay? Respiratory failure, the clinical description is going to be inadequate oxygenation, ventilation, or both, right? And the functional description is basically this requires intervention to prevent arrest. If you do not do something now, not in 10 minutes when you get to Children's or Glennon, right now, if you don't do something, this kid will very surely probably die, okay? They do not hang out in the respiratory failure area long. Very clearly, or very quickly do they decompensate and end up dying. So when you're doing your assessment, first thing, your general appearance when you walk in the door. What does the kid look like? Okay, you can tell if a kid is sick or not sick. You guys learned about the PAT, right? The pediatric assessment triangle. If you've ever taken PALS or EPC, it's in both of them. But the first thing you do when you walk in the door, your PAT, right? Appearance. So what do they look like? Their work of breathing, okay, and then their circulation. So what does their color look like, right? All of that you can see from the door. What is their rate, which again does matter. You should be counting their respiratory rate. Breath sounds, and I don't mean listening here and here, okay? You need to listen to their whole back. Accessory muscle use. How can you tell if a person has accessory muscle use if they're an infant? Can you tell if they're in a pumpkin seat wrapped in 6 parkas in a blanket strapped to the back of your cot? Please, for the love of God, get these kids naked, or at least lift their shirt up and look at their chest. You can't, stop laughing. You cannot tell if a child is having respiratory problems strictly based on looking at the kid when they're in a pumpkin seat and looking at their face, okay? You have to look at their chest. Level of consciousness, so are they paying attention to you when you walk in the door? Right, everybody learned about developmental ages and stages and such in kids, right? So if you walk in the door, most kids, when they're above like 9 months of age and older, should notice you and should pay attention. They should be tracking you and looking at you, okay? Sorry? Or they can cry. I like crying kids, that means that they're alert. If they're not crying and they're lethargic and they don't care that you're holding them or doing things to them, that's probably an issue. Color of skin, mucous membranes, those also matter. So when you're looking at their mucous membranes, you should be looking at their tongue, their gums, everything else. So everybody knows what retractions look like, correct? All of these here, okay? This is not normal. You should not see this in children. If you do, and their pulse ox is 100%, you should still be giving oxygen. So again, their general appearance, are they able to maintain their airway adequately, or are you having to do something to maintain it mechanically? So can you do it with just positioning or suctioning? So if they can't breathe because they can't, if there's mucus in their airways, again, we need to suction. Once you've suctioned it, they get better, then that's all right. But if they're unmanageable, no matter what you do, then this is the indication for airway management, like oral airway, BVM, intubation down the road. Siegler will tell you that you have better, because later on we'll talk about intubation in these kids and when you should intubate. I will put a caveat in there and I will say you can use an I-gel as well, because as he will tell you, there is a better success rate with I-gels than there is intubation. So it's dealer's choice. He gives you the option. I will say don't mess around in their airway for 15 seconds looking. If you don't see it right away, just drop an I-gel. Slow, irregular respiratory rates are an acutely ill infant. This is a very ominous sign. This is to the point where they're almost to the point of no return when they're already have a very slow respiratory rate. Okay, this is the respiratory failure area. Big red flags with respiratory distress. The first sign that you're going to see is tachypnea. Okay, that's why that respiratory rate really does matter. All right. Changes in mechanics of breathing, so if you see any type of retractions, if you see that nasal flaring, if you see anything like that at all, for some kids, like with asthma, if they start tripoding even in their own way, this is a change in mechanics of breathing. They're trying to get their chest bigger to take in more air. Please, for the love of God, don't just leave these kids at home. Any change in breath sounds, okay? And again, that means you listen to the whole back, not just the two front right here. Late signs for respiratory distress moving into failure is going to be your dusky or blue colors, slow or apneic breathing, decreased level of consciousness, and then bradycardia. So most common cause of bradycardia is
respiratory.
Right, so hypoxia, you need to fix that. Okay? So Central nervous system, things that could insult the central nervous system. Immaturity, so we don't have any immature infants up here in North County, correct? None at all.
Just paranoids.
I would agree with you there. But depressed by narcotics, barbiturates, and anesthetics. We have quite a few actually that show up, and a lot of them we don't even know about until after we've done drug screens and such, but the kid's just lethargic and we don't know why. Lots and lots of them are because they were exposed to some sort of a narcotic. And please don't assume that just because a kid's like 1 year old, they weren't exposed to heroin, because it absolutely happens. We see it all the time. So be on the lookout for this kind of stuff, all right? And I will say, just like my own little soapbox when it comes to anyone with heroin or narcotic overdose in general, they are not Narcan deficient, they are oxygen deficient, okay? They need oxygen.
So,
An airway.
You sure?
It is not an airway. But
thank you for everything.
you're welcome. Probably should write that down. Central nervous system disease, insult, or injury. The big disease ones I'll talk about a little bit more with Trish. A big one that we have that has moved into the area is central hypoventilation syndrome, which I don't know if Trish is actually going to talk about that one. But she lives right inside of Florissant, and I know we back up Florissant pretty often. But she is a STARS patient, and basically what she does is she just likes to stop breathing randomly. She does have a trach, she's on a vent, she's got a backup alarm, mom's very educated. However, things like this that affect the central nervous system, these diseases, just cause differences in your ventilation. Okay, so if you walk up, just like you would with every other patient, and the kid's not breathing correctly, there's an issue with their rate, then you fix it, okay? Their airways in general, they have a lot of mucus accumulation. Kids are gross, they're snotty, they have a lot of stuff, a lot of mucus that comes out of a lot of different orifices, so please fix that by suctioning or however you can. Edema, that can be a couple different things. We'll talk about croup here in a little bit, bronchiolitis, things like that. But just edema in general, if you see it, be aware that it may cause an airway failure in the future. Their musculature is incompletely developed, which does come into play. They cannot they compensate like this for quite a while when adults kind of just go in a downhill slope. But when they stop compensating, they drop right off. Okay, so their little muscles can work for a while and then they just stop. There's no teetering. Their ET tube is easily displaced and very easily occluded. In an infant, if you've ever intubated one, you know that the trachea between the vocal cords and the carina is only about 7 centimeters. So it's very easy to right main stem, and also very easy when you're not using a cuff tube to displace that if you move the kid. Okay? If you're going to intubate, how are you going to secure that tube in the back of your truck? What do you have in the back of your truck that can secure a tube in an infant? Monica? Nasal cannula. Thank you. If you don't know that trick, please ask Monica. She actually taught me when we worked together. Tape does work, but a nasal cannula also works pretty well, and you don't have to mess with the face and everything when you do it. The plastic folds on that plastic and it gets sticky and then it won't come out. All right. Chest wall. So if you have an issue with their chest wall, such as trauma or things like that, kids do get ascites if they're in like liver failure and things like that, which we do have kids that have that. All of that puts pressure on the diaphragm, which puts pressure on the lungs, and they don't ventilate very well. The respiratory muscles, like I said, they've got lack of tone. They're very easily fatigued. They're extremely compliant, meaning the littlest bit of work works those muscles very, very easily. Okay. The lung tissue, so pulmonary edema, contusions, things like that. What is a lung tissue disease that you learn from PALS that kids get pretty often in the wintertime? Lung tissue problem.
RSV.
Pneumonia. Bronchiolitis would be too, but pneumonia. Okay, so that's an issue with the tissue, right? If you've got an issue with the tissue, they need oxygen. Sometimes you can give steroids, they need antibiotics. You can get that at the hospital. But if it's a tissue problem, that's what you need to do. So different pediatric respiratory emergencies, all right? Bronchiolitis. So this is swelling and mucus buildup in the bronchioles, okay? It's almost always caused by a virus. It usually affects kids under 2, but it will peak in like the to 3 to 6 months. RSV is the most common cause. This is something you guys will see this winter, I promise. More than half of all infants are exposed to this virus by the time that they reach their first birthday. If anybody has any kids who've ever had RSV, Jackie Clucker, these kids can get sick, and they get sick quick. And sometimes they do require oxygen to get through this. So if you see a kid and they end up with just like cold-like symptoms, a lot of times they're working their way into RSV. And don't just say, why don't you call your pediatrician in the morning and leave the kid there, okay? My own little soapbox also, if you walk into a call expecting a refusal, you've already failed your patient and this profession, okay? Do not go expecting a refusal. Please, for the love of God, do actual assessments on these kids. Risk factors for bronchiolitis, you guys will see none of this in North County, but cigarette smoke, anyone less than 6 months old, crowded living conditions, not being breastfed, and then premature kids. So like 99% of the calls that you run on peds will have at least one of these. It starts off similar to a common cold, but then it starts progressing. And these kids, like I said, they'll be okay for the first day or 2, and then they just crump pretty quickly, all right? The symptoms can last several days to weeks and sometimes even months. I'm not saying they have to be in the hospital for months, but in order to get over that, they will still have some of those symptoms for quite a while. Your symptoms are wheezing, a cough, often associated with vomit, so if they start to retch really hard, sometimes they will vomit. Fatigue, they'll be feverish. Retractions, nasal pharynx, tachypnea, they'll have that nasal congestion or a runny nose. But all of these can be symptoms of bronchiolitis. So, there we go. Common in premature infants, some of the earliest signs for bronchiolitis is going to be apnea spells. Okay, so if they have those apnea spells for 15 to 20 seconds, that can be indicative of bronchiolitis. What is your treatment for bronchiolitis here at KEMS?
Racemic.
Thank you. I think you're the first person that has known that out of the 3 medical director meetings. If they're in severe respiratory distress, they get racemic epi, okay? So first thing, pulse ox, ET, CO2, okay? So make sure you're monitoring those. Then you start giving oxygen by any means necessary. If you've got a kid that will not tolerate a nasal cannula or a non-rebreather, how can you give oxygen to them? Blow-by. How do you give blow-by to a kid?
Blow in their face.
Blow in their face. Very good. please don't blow in their. I mean, if you're going to use oxygen, don't like physically blow in their face. Please do not grab a pediatric nasal cannula and put it on 4 liters and just like have it sitting on the kid's chest or something. Okay. Turn it up, get as much oxygen as you can into the atmosphere, and then give it to them around their face. Okay. Also, don't put 4 liters on a non-rebreather; it doesn't come out. Right? Which is what we have seen. If they get to the point where they're still having severe respiratory distress at rest, okay, at this point in time, you're going to give this kid racemic epi, okay? So if anybody saw Nick's amazing video on how to mix racemic epi, if you decide that you don't want to do that, you can't just give cardiac epi, which is just 5 mils of your brown box, just squirt half of it out into a nebulizer and start to nebulize that. But if you're going to give racemic epi, as far as I know, I've not been told differently, but it comes mixed or not mixed with the saline, correct? As far as I know. So it's 0.5 mils in the, just like, in your, whatever, ampule, I guess, I don't really know. But 0.5 in there, and then take a flush, squirt 3 cc's into your nebulizer and nebulize that, okay? Or you have your cardiac epi, which is just 5 mils of your cardiac epi. Croup, another big one, that's going to be swelling around your vocal cords. Viral croup is the most common. 75% of the time it's caused by the parainfluenza, but again, it can be caused by RSV, measles, adenovirus. If anybody's ever gotten a letter from me about a respiratory kid, they were probably positive for the adenovirus. A lot of kids are. But it's 3 months to 5 years. Okay. Prior to vaccines and antibiotics, this was actually deadly, and it's making a comeback because we're not vaccinating our kids again.
Okay.
Did you say because it causes autism?
That's what I didn't say that.
Oh, it's actually right. So, if everybody's learned about croup, you hear that it's all this barky cough and things like that, but it can also just sound like this, okay? They're swelling around the vocal cords. So it can sound like that, or this guy. Don't act like you're not impressed. There she is putting essential oils on his chest.
Lavender.
You just
Need a little peppermint.
rosemary. He's fine.
Just open those airways right up.
It's funny that you say that because it happens a lot. Or onions, garlic, all of that. So, symptoms of croup. Okay, a mild cold, okay, barking cough, stridor, okay, different from bronchiolitis because it doesn't have wheezing. There's a difference between wheezing and stridor, upper area versus lower. It gets worse at night. The first normally 5 to 6 nights is how long it lasts in general, sometimes a little longer, but the first couple nights are the most severe. Please do not tell these parents, oh, just put them in a hot bath, it'll be fine. Please don't do that. What is your treatment, other than a hot bath, for croup here at Christian? Kepi, okay? Before that, we're going to do obviously your pulse ox and your ETCO2, all right? Then you're going to give your oxygen. Again, if they will not take it, if they won't let you put a nasal cannula or something on them, then just do blow-by. If they're in severe distress at rest, what they get is racemic epi, okay? The concentration, everything is the same as what you would give for bronchiolitis. The only difference here is you're also going to give them steroids, okay? They get Dex. The max is 10 milligrams, so you're going to give 0.6 per kilo. You can give that PO, IV, or IM. There was a question last class on whether or not you can aerosolize Dex. I do have an email into our, just because it tastes gross. So apparently when they squirt it in the kid's mouth, a lot of times they spit it out. So I'm checking to see if we can aerosolize it because you can give it PO. So I'm trying to speed it up. So you would just mix it directly. I'm sorry?
You mix it with the pediatric Tylenol so it doesn't taste bad?
I don't. Again, I have to ask the pharmacist. I don't know.
But you can put it in the nab.
That's what I'm asking. I asked don't do that yet, but I'm just saying that may come down the line eventually, or whether or not you can just aerosolize it. There also was a question of whether or not you could give IV form of Benadryl PO. I also asked that to see if we could give that to kids instead of having to stick them if they're having like a mild allergic reaction or something. So I'll let you guys know what comes down the line, but or we could just get that. But in the meantime, I have asked. We'll see what they say. All right, asthma. So 23 million people in the United States have been diagnosed with asthma. 6.7 million are under the age of 18. I'm fairly certain at least 6 million of them live in North County. Asthma accounts for 13 million school absences per year, which is a lot considering asthma is fairly controllable. Okay? And it's the third ranking cause of childhood hospitalizations in kids under 15, which is a lot. Kids are very accident prone, so trauma's up there as number one, but asthma is an issue, a very fixable issue. Yes, ma'am, sir. Sorry about that.
Per protocol, we can do
Perfect. Will you text Danny Dalton?
We don't have it.
Yeah, we don't have that. So,
I'm aware of that, but they were asking if they could get a PA. What other form would we have?
I don't know, we're gonna show them.
The problem is they don't like it because it's very salty, because it's mixed with saline, so they spit it out. Did you just? So,
This is gonna help.
I'm trying to, asthma, if you're talking about the anatomy of an asthma attack, right? This is why with asthma you end up with like air trapping, is because air can get in through these bronchioles that are constricted here, but then it can't get out. So once it hits the alveoli, you get your gas exchange, but then it can't get back out. So we have kids with air trapping. If you talk about a prolonged expiratory phase, okay, that means that a normal person, your ratio of breathing would be like 1 to 2, but a kid with a prolonged expiratory would be more like 1 to 3 or 1 to 4. And it's because it takes them a really long time to get that air back out. It can go in, but it can't get back out because it gets backed up. You will also notice they have a lot of excess mucus here. Okay, that's why kids cough when they have a lot of asthma. They're trying to get that out. Encourage kids to cough. The exact cause of asthma is not known. It is partially inherited, but it does have a lot of other factors. These are different triggers that you can have for asthma. Allergens, changes in weather, chemicals, exercise, infection, just stress, a lot of tobacco smoke, things like that can cause a trigger in an asthma attack. First thing, after a child is exposed to a trigger, the body releases histamine, which causes this swelling here inside the bronchioles. Okay, it's a histamine release. Causes increased mucus production. And then your symptoms are your cough, you got retractions, shortness of breath, wheezing, prolonged expiration. Sometimes they'll have chest pain, tightness. A lot of the older kids will call it in as chest pain instead of actual difficulty breathing. What I will say is you notice that there's no cold symptoms here. There's no fever, there's nothing like that. You can have that, which can cause asthma exacerbation. It's like upper respiratory infections can cause asthma exacerbation. So just because you don't see, or just because you do see a fever and things like that does not mean that they're not having an asthma attack. So your treatment, what is it? What bronchodilators do we have in the truck?
Buterol.
Buterol. Atropine. Epinephrine.
Thank you. I was waiting for that last one. All right, so first thing, your pulse ox, ETCO2, check your lung sound, start giving oxygen. Your NEB treatment, that's going to be 5 milligrams, and it is unlimited. Okay, so just keep going. Atropine, you can give up to 3 times for a max of 1.5 milligrams. This is for any age. Your Dex, again, and this says all patients with bronchospasm, whether you transport or not, get Dex. Okay. What was that? Mag sulfate, so if you're getting into the point where none of this is working and they're not turning around quickly, then we can get into our mag sulfate administration. We do need an IV, so up until here, you don't need an IV, okay? Everything else you can give PO. If you're going to get into the mag sulfate, at that point in time, it's 25 milligrams per kilogram, which sounds